20-year-old girl who came with the RBS of 500 milligram per deciliter. Very high blood sugar. There was a present ketone was present, and as you can see, in the blood gas pH suggestive of that there was a metabolic acidosis. So here there was no dilemma. Patient had a diabetic ketoacidosis, as seen the picture of the sugar high, ketone high, and the pH low, and potassium was 4 millimole per liter. That was normal. Treatment has been started. Patient had started on the fluids and the insulin, and after sudden, patient developed the arrhythmia and death happened. But what was the reason for the death in arrhythmia? There was a hypokalemia. If you ask me what is the life expectancy of the diabetes type 1 in the India, then it is only 23 to 29 years. While in the USA it is 64 years. Here shock is very unlikely. Why? Because nature is giving cortisol infusion by itself. So if you have a shock in the decay, that is a very severe pathology. In that term, you have to work very aggressively. Clear and loud message is there. You don't have to give the soda bicarbonate because it can cause the cerebral edema. Without wasting the time, we have to start our session. So today we are going to discuss about diabetic ketoacidosis, why it is important to know, and what are the problems that we are doing into daily life. So I want to thank you for the all faculties and respected Medflix team for giving me such a nice opportunity to speak in front of you. So today, this is the first case. 20-year-old girl who came with the RBS of 500 milligram per deciliter. Very high blood sugar. There was a present ketone was present, and as you can see, in the blood gas pH suggestive of that there was a metabolic acidosis. So here there was no dilemma. Patient had a diabetic ketoacidosis, as seen the picture of the sugar high, ketone high, and the pH low, and potassium was 4 millimole per liter. That was normal. Treatment has been started. Patient had started on the fluids and the insulin, and after sudden, patient developed the arrhythmia and death happened. But what was the reason for the death in arrhythmia? There was a hypokalemia. So in the fluid, potassium was not initiated, and that was the reason of the death and arrhythmia. So in this case, potassium should be started. So this is the first case where mismanaged decay can cause the death or mortality. This is the second case, that 13-year-old female who presented with the decay at the first time of the diagnosis. Fluid has been given from the outside. There was a altered sensorium. IV fluid was given. Insulin and the potassium was given. But patient developed edema. Why she developed cerebral edema? What should have been done? This entire 20-30 minutes, we are going to talk about what to take care in the especially in the diabetic ketoacidosis. So we are going to discuss the basic and the beyond the basic of the diabetic ketoacidosis. So if you compare the life expectancy in the type 1 diabetes in India is very rare, very rare. Patients are dying mostly due to the diabetic ketoacidosis. That is the most acute complication of the diabetic complication. If you ask me what is the life expectancy of the diabetes type 1 in the India, then it is only 23 to 29 years. While in the USA it is 64 years. That means we have an absolute good disease, but because of the complication and the poor management, patient had a mortality. And yearly more than 3 lakh cases of the diabetes type 1 is finding all over the world, and India has a more than 10 lakh cases across the nations, and this is the data that has been published in the ISPED Italy 2023. So, what is the epidemiology of the decay? Yearly, you find 40 to 60% cases as a fresh diabetic ketoacidosis, and there is a recurrent more than 10% in the India for the diabetic ketoacidosis. In the type 2 diabetes also, there is 5 to 20% diabetic ketoacidosis happen. So there is not only myth is that diabetic ketoacidosis happen in the type 1 only. No, it is not that. In the 5 to 10% or 20% in the type 2 diabetes, you can see diabetic ketoacidosis. If it happens in the youngest child, then the mortality high, and the higher socioeconomic status, they do have less mortality, while in the lower socioeconomic status, they do have a recurrent diabetic ketoacidosis. And more, what is the reason for the diabetic ketoacidosis? It is due to the missed dose, sick day, or the psychological issue. So I want to ask to the audience, if I permitted, then you can write in the chat box. According to you, what is the incidence of the cerebral edema in the diabetic ketoacidosis in your setting? So you have three options: less than 10%, 20 to 30%, high due to the periphery treatment, or no any incidence. Among them, you can write any questions in the chat box, or you can speak on the while in front of the camera. So I got a poll comment. Yeah. Can anybody guess what is the incidence of the cerebral edema in the DK? You can write in the chat box. Any guess from the audience? Okay. So in the India in the youngest age group, cerebral edema happens 20 to 30% if treatment has been not given properly. So this is the answer, that cerebral edema incidence is very high. And my second questions to the audience: at the what age you find decay to be present with the cerebral edema? So cerebral edema can happen at the any age, especially to the any age group, and this is our case report of the Kanpur Regency Hospital, that we have a 22-year-old male who presented with the cerebral edema with the type 1 diabetes. So it can happen at any age, and this is my all the chapters regarding the ambulatory care of the type 1 diabetes. You can see on the learning.growsociety.in, and you can find how to differentiate the diabetic ketoacidosis and what are the initial steps for this. So, what is the pathophysiology of the diabetic ketoacidosis? It happens due to the insulin deficiency. Not just due to the insulin deficiency, but it also happens due to the increase in the glucagon, growth hormone, epinephrine level. So, it is an excess of the counter regulatory hormones, and by the combination it can cause the acidosis, it can cause the rapid breathing, abdominal pain, but here shock is very unlikely. Why? Because nature is giving cortisol infusion by itself. So if you have a shock in the decay, that is a very severe pathology. In that term, you have to work very aggressively, because generally shock doesn't present with the type 1 diabetic ketoacidosis. And whenever we have an excess glucose, that glucose is trying to excrete from the urine. So it can cause a glucosuria. It always drag the water with it, so it can cause the polyuria. And in the composition of the polyuria, there will be the polydipsia. So you will find dehydration, polyuria, and the polydipsia in the pathophysiology. How to calculate the dehydration? Suppose if you are suspecting 10% of the dehydration, then you have to see that dehydration one step lower. You have to consider it as a 7.5% if you are not sure. You have to give adequate supplements of the sodium, because there is a loss of the 6 to 10 millimole per kg of sodium, and it is mainly due to the pseudo hyponatremia, not for the true hyponatremia. And this is the correction formula, that you have to correct the sodium with the every glucose. And due to the glucosuria and the ketoacidosis, there is a loss of the potassium. So every zero point 0.6 decrease in the pH, you have to, sorry, every zero point 0.1 decrease in the pH, you have to correct the potassium with the zero point 0.6. So suppose if you have a 3 potassium and your pH is 6.9, then at that time, according to this formula, in your body there is no potassium. So initially you have to correct the potassium and you have to transmute the potassium. Otherwise, it can cause the arrhythmia and it can cause the damage to the heart. So potassium is mainstay for the decay management, and if you don't give manage properly, then it can cause the severe ketoacidosis, and it can cause the cerebral edema. So if you are giving more fluid, then it can cause the cerebral edema. If you are giving the less fluid, then you are causing the dehydration. When to suspect the diabetic ketoacidosis? When patient present with the dehydration, with the polyuria, with the abdominal pain, with the trachepnea without the chest sign. If you are putting the stethoscope and you don't have any wheezing, wiry, but respiratory distress is there, in that condition you have to suspect the diabetic ketoacidosis. In some cases, severe cases is present with the encephalopathy. This is the three most important criteria that you have to diagnose by this criteria. It should be sugar more than 200, so diabetes should be there. Ketone should be more than 3 millimole, and the acidosis should be there. pH should be less than 0.7, less than 7.3. This triad is most important for the diagnosis of the diabetic ketoacidosis. And risk of the diabetes in the stress hypoglycemia is there, and sick day management is very important. So I just want to ask to the audience again, which ketone measurement will be the most useful for the diabetic ketoacidosis management? So you have three options. One is the acetone, beta hydroxybutyrate, and monitoring is not required. So you can write in the comment box. What is your comment? Yeah. So what what is your guess that which ketone measurement will be the most useful? What you are doing in your clinical practice? Are you measuring acetone, beta hydroxybutyrate, or monitoring is not required? I am getting the comment. Yes, beta hydroxybutyrate. Yeah, beta hydroxybutyrate. Yeah. Okay. Thank you very much. Acetone. Somebody, Nilesh Patel has wrote the acetone. Yeah, Mohammed sir has been wrote the, yeah, Siddharth is right. Yeah. So there is a lot of comment is going on. Thank you very much for the taking interest into the interactive session. So some people are monitoring the acetone and some people are monitoring the beta hydroxybutyrate. But if you ask me, then beta hydroxybutyrate is most important marker for the diabetic ketoacidosis, because acetone is only 12% of the ketone what we have. Beta hydroxybutyrate is major metabolite, and it is direct metabolite of the ketone. So if you measure the acetone, then it is falsely positive for the longer duration. Suppose if you have resolved from the diabetic ketoacidosis, then also it could be falsely positive. But in terms of the beta hydroxybutyrate, it is a very nice monitoring tool. So whenever you have a patient, try to measure beta hydroxybutyrate, not acetone. Uh, so this is my explanation. Okay, suppose after your resolution of the beta diabetic ketoacidosis, sometime acetone may be present. So you have a false illusion that patient is in the diabetic ketoacidosis, but actually patient is out of the diabetic ketoacidosis. So you have to measure the beta hydroxybutyrate, and sometime they do have a ceiling effect. In that time also beta hydroxybutyrate could be the positive, but you have to see the clinical condition. If patient is well taken orally, there is no abdominal pain, there is no distress, and that time you have to shift over the subcutaneous insulin. How do you do have to do a ketone assessment? You can have a point of care machines available. Acetoacetate is only 12% in the decay. There has a delayed rise, persistent and moderate to large variation is available, while beta hydroxybutyrate is the most important marker, and but it is very unreliable at the higher level. So again, there is a drawback of the beta hydroxybutyrate also, but majority of the case you have to monitor the beta hydroxybutyrate. What is the interpretation? More than 3 millimole per liter, there is a ketosis. Points less than zero point 0.6, it is normal. So in that patient, you can send back to home and you can ask to them for the sick day management. If less than 1 millimole per liter, then you can confidently tell that patient is out of the diabetic ketoacidosis. Yeah. So, what is the management of the diabetic ketoacidosis? You have to work with a tight rope. Why? Because too much fluid can cause the cerebral edema, while too little fluid can cause the acidosis. So, you have to give the particular amount of the fluid. You have to avoid the hypoglycemia as well as the hypokalemia. First patient comes, then you have to secure airway. If the patient is unconscious, then you have to insert the gastric tube, and you have to put the two white gold lines. From one, insulin can be can go, and from the one side fluid can be given. So you have to put the two white gold lines in this kind of the patient. You have to avoid early intervention because it can aggravate cerebral edema. You have to avoid the central line, and too much fluid should be not given because it can cause the cerebral edema. Shock is unlikely, but if shock is there, then you have to exclude the sepsis. Most important. If patient has a hypotension, then you have to exclude the shock again. You can give the antibiotic if fever is there, and in the cerebral edema, you can give the mannitol instead of the NaCl. So, just I want to ask to audience again, what is the best clinical parameter to assess the severity? You have three options. One is the capillary rippling time, one is the oral mucosa, and third is the blood pressure. So, by which parameter is most useful to assess the severity among three? Yeah. The From the audience, you can answer. I'm getting very nice answer. CRT, okay. BP, okay. Capillary rippling time, okay. Oral mucosa, okay. So now we will discuss what is the good parameter. Okay, let's answer this question. So suppose if you are assessing the severity by the oral mucosa, then at the 10% it may you will find it is very dry. So might be you will underestimate the oral by seeing the oral mucosa, because patient are taking breathing from mouth like this kind of the situation. So in that oral mucosa would be dry. So might be you are overestimating the dehydration. If you are seeing the capillary rippling time, then you have a nice result. So that is a good marker. If you are seeing the blood pressure, then only in the severe dehydration you will find the hypotension. Otherwise, you are going to miss the moderate to severe dehydration. So it is not a good marker. Pulse and the capillary rippling time is a good marker to assess the severity. How do you classify? There is a three category: mild, moderate, and severe. If your pH is less than 7.2, then you have a level less than 7, then it is a severe category. 7 to 7.1 is a moderate category. 7.1 to 7.2 is a mild acidosis. According to bicarbonate, if it is less than 18, then it is a mild ketosis. Less than 10 and less than 5 is a moderate to severe ketoacidosis. Why we want to classify? Because in the mild cases you can send patient back to home, you can manage it by your OPD setting, but in the moderate and the severe case you have to monitor it by the HDU at the or in the ICU. Patient may take a time from recover from the glucosuria and the glucosis. It takes 6 to 8 hours to resolve the hyperglycemic condition. For the ketoacidosis, it takes 10 to 12 hours for the resolution, and for the acidosis, it takes 14 to 18 hours for the resolution. So this is the decay management. And the first hydration phase, you have to give the bolus of the sodium normal saline. That should be given 10 ml per kg. If the dehydration is there, then you can double the dose. While in the insulin phase, you have to give the deficient plus the maintenance fluid. It should be given for the 48 hour. Then you have to start with the insulin point 1 unit per kg per hour, and you have to start with the potassium. Unless and otherwise, if it is hyperkalemia, potassium is more than 6. In that case, you have to avoid the potassium. Otherwise, you have to start the potassium. And once sugar is becoming less than 300, you have to add the dextrose fluid. So clear and loud message is there. You don't have to give the soda bicarbonate because it can cause the cerebral edema. So you have to give the fluid bolus when you have a tachypnea, shock, and fluid bolus is also important in the mild decay. So suppose if any patient is there, you want to treat at their home, but give just a bolus, so that dehydration will be corrected. Their cortisol and cortisol and stress hormone will be less. So by that you can prevent the decay. So in the mild decay also, by just giving the bolus, it will be very helpful. And those you can give 10 to 20 ml per kg, and you have to not should be given more than 40 kilogram in the 40 ml per kg in the 4 hour. So this is the calculation of for the maintenance and the deficient fluid. But if you see the guideline, in the guideline, they were asking that any amount of the fluid you can give. But this is created from the Western countries, so it is not a general. It is not commonly used in the resource poor countries like us, because we have a very severe ketoacidosis. So if we give up more fluid, then it can cause the cerebral edema. So it is not useful for the Indian setting. You have to give the intravenous insulin. If that is it is not available, then you can give the IM injection. But now that practice is vanishing. The dose of the insulin is 0.05 to zero point 0.1 unit per kg per hour, and you have to flush the tubing. Why? Because insulin is likely to stuck at the piping. So you have to flush the tubing. Slow change should be done, and you have to avoid the over dilution. How to do a monitoring? You have to monitor for the GC scoring. You have to see the dehydration improvement. You have to see the urine output. If it is urine output is more than 1 ml per kg per hour, then patient is not in the shock. Patient sodium and potassium should be stable, and there should be improvement in the ketoacidosis. So this is the question, that this is the very young patient who developed the cerebral edema. In that kind of the patient, you have to monitor the GCS. In this case, monitor is better than the 3% NaCl, and you always have to give a slow fluid correction, not a fast fluid, but very slow fluid correction should be given. What is the requirement of the potassium? Suppose if potassium is more than 6, then and then you have to avoid. Otherwise, in every case, you have to replace with the potassium, which is the most important things that you have to do in the management of the diabetic ketoacidosis. If potassium is less than 3.3, then you have to add in the hydration phase. If it is borderline 3 to 3.6, then you can add in the maintenance phase. If you develop the myopathy or the polyuria, that is a pointer of the hypokalemia. And suppose if potassium is very low, then that point of time you have to stop the insulin infusion, or you can reduce the insulin infusion. Potassium again is very important. Suppose if your blood sugar is falling beyond 300, then you have to add the 5% dextrose in 200 to 300 milligram of the sugar, and if it is less than 200, then you have to add to 10% of the dextrose to avoid the hypokalemia. Suppose patient is out of the diabetic ketoacidosis, but you are monitoring the ketone. If ketone is more than 2 millimole per liter, then uh, you can tell that patient is still in the diabetic ketoacidosis. But if it's less than 2 millimole, but chloremic load, if you measure, then it is above 32, then you can tell that it is due to the your fluid, it is NS. And if it is below 732, then you are dealing with the lactic acidosis. So you have to correct the lactic acidosis. So this is how you have to do interpretation. Other important condition from the diabetic ketoacidosis that easily you can mimic as a diabetic ketoacidosis is a HHS, hyperosmotic hyperglycemic shock. What is the difference? In the HAS condition, you have very high sugar, more than 600. There was a little or no or mild diabetic ketoacidosis. So pH is around 7.3. There is no ketosis, but there will be severe dehydration than the diabetic ketoacidosis, and there is a more electrolyte loss than the diabetic ketoacidosis. It is very difficult to manage this kind of the condition because of the because it mainly present in the type 2 diabetes, and it is rare also, but if it is there, then you should be aware what is the HHS and what is the diabetic ketoacidosis. So this is my now we are going to the we are about to complete our session. I am going to ask to everyone that this is the 3-year-old boy who has a sugar more than 230. Blood pH you have done, that is suggestive of acidosis, but there was no ketone. And patient has started on the DKA management and developed the hypoglycemia. So, can you comment what was that? Is it diabetic ketoacidosis or it is something else? You can write in the comment box. Can anybody can comment what is it? Is it a diabetic ketoacidosis or is it? So this is not a diabetic ketosis acidosis. Why? Because by definition, diabetic ketoacidosis means there should be diabetes more than sugar should be more than 200. In this case, there it was there. Sugar was 230, so diabetes is there. There was a acidosis, so pH should be less than 7.3. So here also pH is 7.2. So acidosis was there, but ketone should be more than 3. Ketone was not there. So it is not a diabetic ketoacidosis, it is a diabetes plus acidosis. So this is not diabetic ketoacidosis, it is a stress hyperglycemia. So just you have to manage with the insulin, or you just have to give the sick day management. By that you can avoid the avoid this condition. So this is the stress hyperglycemia. This is the second question. 5-year-old boy, RBS is very high. Ketone was present and pH is 6.8. So this is diabetic ketoacidosis because triad is matching. But here potassium is very low, 3.1 millimole per liter. So what is the management should be done in this case? So here potassium is very low. So we don't have to start insulin here. We just have to give the fluid, and then in the fluid bolus we have to add the potassium. Because if we start insulin, then insulin can cause the further hypokalemia. That can cause the arrhythmia and can the mortality. So potassium should be corrected first in this case. This is the third case. Sorry. Yeah. So this was the third and last case. 3-year-old girl presented with a severe diabetic ketoacidosis. Taken fluid from the outcare setting. Patient presented with very low GC. What is the management? So here it is looking like the patient may develop the cerebral edema. So here mannitol should be given and patient should be given the slow fluid correction rather than the fast fluid correction. So here very important message is there that you don't underestimate the hypokalemia because it can cause the mortality. For the diabetic ketoacidosis, there should be tried diabetic ketosis and acidosis. And third case, you don't have to miss the cerebral edema. Otherwise, mortality would be there. So three most loud and clear message from this setting that You don't have to miss the diabetic ketoacidosis. Potassium should be corrected first, and if the cerebral edema is there, then you have to treat with the mannitol. So this is the end of my presentation. That we discussed the diabetic ketoacidosis from the basic to the beyond basic. If you have any questions, then I would like to welcome your questions. Thank you very much.
Thank you so much, sir, for the presentation. If you have any questions right now, you can keep, add it to the comment section.
Somebody was
Yes, sir. We have a few questions that have come in earlier.
yeah. Dr. Mahesh Mittal has some question. Can if you read it out?
Yes, sir. Is continuous insulin infusion more effective than 6 hourly doses scheduled for DKA?
Uh, what was the question? I could not able to see.
It's on the screen as well. Is continuous insulin infusion more effective than 6 hourly doses scheduled for DKA?
Yeah, in the diabetic ketoacidosis, we have to give the continuous insulin infusion to prevent the diabetic ketoacidosis. Because whenever we have a insulin deficiency, it can cause the ketosis and the acidosis. So we have to replace it via the continuous manner, not in the intermediate manner. So, but in the research poor setting, sometime in the periphery, we don't have access for the insulin infusion pump. In that particular case, you can give the multiple bolus, but that is not advisable by the recent ISPED guideline and the ADA guideline.
Yes, sir. Thank you. We have another question by Dr. Vidhi Thakkar. What are the most prominent symptoms which are more highly points towards diabetic ketoacidosis?
Yeah, very nice question. So, prominent symptoms would be there: abdominal pain. If the type 1 diabetic patient has an abdominal pain, then mostly it is due to the ketone productions. So if the abdominal pain is there, then that is an alarming sign. You have to measure the ketone that time. If they do have vomiting, then another alarming symptoms is there. So abdominal pain and the vomiting is the most prominent and most common symptoms of the diabetic ketoacidosis.
Yes, sir. There's one more question by Dr. Mahesh. Not all patients with glycosuria, say blood sugar above 400 or HbA1c above 12, come with diabetic ketoacidosis. Why is it so?
Not all patients with the glycosuria say blood glucose above 400 or HbA1c above 12. Yeah, so diabetic ketoacidosis is not just about the blood glucose of more than 400 or more than HbA1c is more than 12. Suppose if you have a HbA1c of 8, but if you are not taking any insulin for the 5 days, you will have a diabetic ketoacidosis. So it doesn't matches with your blood sugar or the HbA1c level. It is matches with your insulin deficiency. So suppose if any person has a HbA1c of 6.5, suppose if he is not taking the insulin for 5 days, then he can develop the diabetic ketoacidosis. So it doesn't match with the like always match with the blood sugar level or the HbA1c level. In the majority of the case, what happens nowadays, especially in the summer season, they are very nicely controlled with the HbA1c. Their HbA1c is around 7 to 8, but they went to the marriage, they are eating gola, pani puri and everything. They got sick and because of that poor sick day management, they have a diabetic ketoacidosis.
Yes. So there is a similar question about the role of HbA1c. What is the role of HbA1c in diabetic ketoacidosis? By Dr.
What is the role of HbA1c in the what context? Okay, if I understood your questions, then HbA1c is very important marker for the monitoring. You can assess the level of the control by measuring the HbA1c. So every 3 monthly it should be done. So suppose your HbA1c is 15. So after 3 months, if it is 12, then you can say your control is very good. If it is 6 and it is becoming 7, then you can say control is bad. So you can monitor over the periods.
So there is a question on when to give bicarbonates.
Yeah. So unless and otherwise potassium is more than 6, if you are correcting the acidosis by every measures and as there is a no corrections of the acidosis happen, if there is need of the renal replacement therapy, in that case potassium is required. Otherwise you have to avoid bicarbonate, you have to avoid bicarbonate, you have to avoid bicarbonate.
Yes, sir. There is a question by Dr. Abhinav. How to manage a diabetic ketoacidosis in patients with heart failure?
Okay, in the heart failure patient, it is very difficult because we don't give much fluid in the heart failure patient. So it should be under guidance of the cardiologist and the endocrinologist. In particular setting, we have to give the minimal fluid and we have to give the insulin infusion. So here fluid should be restricted, but you can give the intravenous insulin infusion.
Okay, thank you. Sir, we have a question by Dr. Chaitanya. How to convert infusion to intermittent dose after resolving acidosis and ketosis?
Yeah, very nice question. So suppose a patient has a type 1 diabetes and patient had a weight of 150 kg. Then at the transition, you have to calculate the dose with the 1 to 1.5 international unit per kg per day. So you have to start with around 60 unit per kg per 60 unit per day. So that dose should be divided into the 50-50. In the first 4 to 7 days. 50% should be the bolus or 50% should be the bolus. And it should be given by the 4 injections in the type 1 diabetes. Some people are using the 40-60% ratio. Means 40% should be basal and the 60% should be the bolus dose. So this is how we have to do conversion.
So we have a question from Dr. Abhinav. How to calculate the chloride gap?
Yeah, you have to monitor the from the NN gap. You have to do the ABG. You have to calculate by the ABG. If the calculated NN gap is more than 32, then it is a dichloremic load. In that case, you have to avoid the normal saline. You can give the plasma light solution. If it is less than 32, then you can put a diagnosis of the lactic acidosis.
So there is a similar question by Dr. Sorry. The importance of anion gap in closure of. Wait, I'm sorry. The importance of anion gap closure to continue the insulin drip.
Can you repeat it again? I'm
What is the importance of anion gap closure to continue the glucose drip?
Yeah, generally we don't measure the anion gap for the continuation of the insulin infusion because the diabetic ketoacidosis is high anion gap condition. So we rather than the anion gap, we generally measure the ketone level and the acid level. If it is in the downgrade phenomena, then in that case we can say it is a resolution of the diabetic ketoacidosis.
So we have a question here on what are the risks of cerebral edema in diabetes ketoacidosis treatment, especially in children.
Yeah. So if you ask in the Indian scenario, because in Indian condition, diabetic ketoacidosis may present with the severe ketoacidosis. In the most cases, the pH is less than 6.9. So here, the risk of the cerebral edema is very, very high. Particularly if patient is cataxic, if they have a hypokalemia, and if they are coming from the lower socioeconomic status, because the condition is generally missed. So in that cases, there is high incidence of the cerebral edema more than 10%, particularly into the different setup. And if you ask in the higher socioeconomic status, then the level would be the incidence is much less. But in the younger children, the incidence is much high.
Uh, to continue the same question, we have a question with Dr. Rajveer. How to recognize cerebral edema in DKA patients who may require mannitol?
Okay. So for the decay, for the identification of the cerebral edema, you have to monitor the GC score. If GC is calling, then it is an important sign that you patient may develop into the cerebral edema. Second sign is sodium. Suppose patient has a persistent hyponatremia or hyponatremia is worsening, then that is the second sign that patient may fall into the cerebral edema. Third, most important sign is patient may develop the seizure. If they develop the abnormal pupillary reaction, that would be the sign. You can revise the Moore criteria that is given in the AIMS protocol. If the patient is according to the Moore criteria, they do have a different major and the minor criteria like seizure, hypotension, hyponatremia, BP fluctuation. In according to that criteria, you have to diagnose the cerebral edema.
So we have a question by Dr. Praveen. How is the management of euglycemic ketoacidosis different from DKA?
Yeah. So the euglycemic ketoacidosis mainly happen due to the SGLT2 inhibitor, where you are giving the SGLT2 inhibitor. The SGLT2 inhibitor is causing is causing that glycosuria. So in that case, there should be no diabetic ketoacidosis. There should be the sugar is always less than 200 or around 200. You won't find the sugar of 400 because of the glycosuria, but it is mainly due to the ketoacidosis. Ketosis is there and acidosis is there. Here, the development of the diabetic ketoacidosis is more due to the fluid loss. So here, fluid replacement should be the first line of the treatment rather than the ketoacidosis. So you have to correct the dehydration first in the euglycemic ketoacidosis. Otherwise, management is pretty simple. Just you have to avoid the dehydration. And in the background, you will always have a history of the taken any empagliflozin or the dapagliflozin.
The next question is when to overlap IV insulin infusion with subcutaneous insulin and which type of insulin is better for overlap and continuous maintenance.
Yeah, for the overlapping, always you have to start with the previous night. You have to give if you suppose if you want to switch over from the infusion to the subcutaneous insulin tomorrow. Then by today night you have to give the long-acting basal insulin. Either it could be the glargine, it could be the Lantus, according to your choice. And on the second day, at the day of the switch over, you previous the half hour before the meal, you have to give the regular insulin or the analogs insulin. Then you have to do a overlap of the insulin infusion for the half hour, and then you can finally switch it over to the subcutaneous insulin. And that basal insulin you have to give every day at the same time, preferability at the mostly in the night time 10 p.m. you have to give that.
So there are two questions about HbA1c. What will be the HbA1c for control type 1 diabetes in a controlled
Okay. So previously 7.5 was a cutoff for the type 1 diabetes control, but now the definition has been changed. It is 6.5. So any condition the HbA1c should be less than 6.5. But it varies. Suppose if you are dealing with the children, then you don't suspect the HbA1c should be less than 6.5. Otherwise, you may have a more hypoglycemia. So according to the age group, you have to define your goal. In the adult, you have to always to be less than 7. In the practical perspective from the Indian scenario, if you ask me, then your HbA1c should be less than 7.
So it's A similar question: in a poorly managed diabetic patient, what should be the HbA1c level be?
Yeah, in the like it should be. I think it should be less than 7.5. The cutoff remains same. If like the poor person or the affluent person develop the fever, we have to give the paracetamol in both patients. Na? So we don't differentiate. So the HbA1c cutoff should be not differentiated according to the socio-economical status or how it is controlled. So for the all patient, the cutoff is less than 7.5. Then and then you can prevent the diabetic complication. Otherwise, after the 5 years, you will have a diabetic retinopathy, nephropathy, everything you will have.
So we have a question on what is the best marker for resolution of DKA.
Yeah. If you are practicing in the resource poor setting, then best thing is clinical assessment. Suppose if you have luxury to monitor the blood ketone, you have to monitor the blood ketone every 6 to 8 hourly. If blood ketone is less than 1, then you can tell that patient is in resolution. If the pH is more than 7.3, then you can tell that patient is in resolution. So these are the two criteria for the resolutions.
So there's a question by Dr. Vinay. Significance on positive ketones in urine in non-diabetic who is not fasting.
Okay. So if ketone is there, ketone is positive in the urine, and patient who doesn't have any diabetes, then and who is not fasting. So we have ruled out the starvation ketoacidosis, but in that condition we have to rule out the metabolic conditions. We have some diabetic ketoacidosis mimicking condition like pyruvate decarboxylase deficiency. In that case, you will have such kind of a situation. Although it is very rare, but you have to rule out the this kind of the metabolic abnormalities.
So about the cerebral edema, how can change in sodium levels help to predict cerebral edema?
Yeah. So suppose if your sodium is 129 and you have started the diabetic ketoacidosis correction. So the sodium should be raised. If you are giving the proper fluid, proper insulin, then it should be around 133 or 135. Suppose if it is falling behind your every proper management, then probably you are giving the more fluid, and because of the more fluid, patient may have a cerebral edema. So this is the marker that hyponatremia can cause the cerebral edema in this particular case.
So continuing on cerebral edema, Dr. Abhinav has a question. Can we give DDAVP to prevent cerebral edema?
No, it will worsen. It will cause the cerebral pontal hemorrhage. So we don't have to do any acute correction. We have to give the mannitol or the NaCl, but we don't have to give the DDAVP.
Dr. Chaitanya has this question. If a patient has hypervolemic state, CKD, CLD, HF, but the patient is in severe acidosis, normally we correct dehydration with fluids. How will we manage this as acidosis can cause cardiac arrest?
Patient has a hypervolemic state, but patient is in severe acidosis. Normally, we correct dehydration with the fluid. How we will manage this as a acidosis and cause the cardiac arrest. So I think in the CKD patients and the severe acidosis in this case, you have if you don't have any options in that case, you have to give the soda bicarbonate uh, under the monitoring under the team, because this is the not normal routine case. It should be managed with the multidisciplinary approach.
Uh, Next question is, what is the reason for diabetic encephalopathy and how to treat?
Yeah. The reason for the diabetic encephalopathy is the osmolarity changes mainly. Suppose your sugar was more than around 200. That time your osmolarity is different, and at the 400 of sugar, your osmolarity is different. So this is the main reason of the developing diabetic encephalopathy. Suppose it stay for the longer duration, then it can cause the changes in the brain. So that is worsen the encephalopathy. And in the cerebral edema, you will have a drowsiness, you will have a seizure, and everything. So it start with the mechanism of the osmotic disequilibrium. And for the treatment, you have to give the proper amount of the fluid you have to give. If the cerebral edema is there, then you have to give the mannitol or the sodium NaCl. That should be 3%.
So Dr. Ritu has asked, uh, if the patient is ongoing medications followed by low glycemic load diet, the fasting blood sugar is under control, but the postprandial blood sugar is too much high. Uh, what is the reason behind the high value, and how can we manage this?
So I will assess the reason behind the IPP2BS where FBS is normal. So here might be the case is that in the Indian scenario, patient is taking too much carbohydrate. That could be the first scenario. In the second scenario, might be your insulin is very low, or technique is not proper, air is going on. We have seen so many cases, Shanika, where patient had a diabetic ketoacidosis because they were injecting air. Actually, they were not giving the insulin because air bubble is there. They were just giving the air to the patient. They were not removing the air. So this is minor details is required for the PP2BS. PP2BS should be in control.
Okay. So here I would like to ask if you want to take more questions, or you like to end the session because we are towards the end right now,
Yeah,
or if you want to give
we can
closing
we can
remarks.
answer 2 to 3 questions more, and then we can.
All right, sir.
I think our audience is so active.
Yes.
They are very enthused for the diabetic ketoacidosis.
Yes. How to manage diabetic ketoacidosis in small hospital setup?
Yeah, so in the small hospital setup, if you have an insulin infusion pump, then you can give the infusion pump. But ideally, there should be some requirement is there. You should have an infusion pump ready. Second thing, you have to put the board needle, and you have to manage in the ICU because it requires a frequent monitoring of the sugar. So that should be must. Otherwise, and unless it will develop the complication.
Yes, sir. Sir, there's one question about to end the question answer session. What is the do's and don'ts for management of DKA? Like,
Okay,
summarize the session.
okay. So do's in the DK that you don't have, you have to give the proper fluid. You have to assess the dehydration, and according to assessment of the dehydration, you have to give the proper fluid. Insulin should be started after correction of the dehydration, and correction should be started very slowly for the 48 to 72 hours. What is the don't for the diabetic ketoacidosis management? You don't have to give a overzealous crew. You don't have to underestimate dehydration. Most important, you don't have to avoid the hypokalemia. That would be the most important factor for your mortalities in the decay. And you should not give bicarbonate. You should not give bicarbonate. That is also most important step.
I think that covers most of our questions today, sir. If there are more questions, we will approach you via WhatsApp to get them
Yeah.
answered later.
Okay. Thank you very much. Yeah.
Thank you so much, sir. If you have any closing remarks for the session, then
Yeah. Thank you very much for providing me opportunity. And I would thanks to all the audience who stayed for more than 1 hour and asking for the so many interesting questions. Thank you very much.
Thank you so much, sir, for joining us